All right. Well, hi everyone, and thanks for joining us tonight. Ooh. So, if you're still experiencing sort of the Olympic come down like I am, you'll be really excited to join us tonight to hear about the latest sports gynae research and what it means for you. And by you, I mean us mere mortals and not Olympic athletes. And I'm really excited to be joined tonight by Dr. Ben. Not only is Dr. Ben one of our consultants, he's also a consultant gynecologist and fertility specialist, and also holds an honorary consultant position at both Imperial and Oxford NHS Trusts. So he has a lot of spare time on his hands. And with that spare time, he has a keen interest in sports gynecology and sports obstetrics. So thanks, Ben, for joining us tonight. And we're really looking forward to listening to some of the latest research you've been doing in this field.
Thank you, and thanks for having me. Yeah, it's something I'm very passionate about, and yeah, something that I mean, obviously, it's been difficult getting over the withdrawal after the end of the Olympics, but yeah, maybe this will bring back some of those positive feelings.
I spent the last few weeks trying to figure out what sport I could perfect in the next 4 years and make it to the LA Olympics. And I really had given up until I saw my very own countrymen do the breakdancing for Australia. And then I decided that perhaps I had a chance after all. But yeah, I think maybe it's best that I stick to my day job and at Hertility, where we're really proud to be offering our users an end-to-end service from testing, diagnostics, and treatment into their reproductive health and fertility. And so we encourage our users to track their hormones and their cycles to optimize their health and make informed decisions about their bodies. Now, for most of us, those decisions involve, helping us determine when we're ovulating or when we're not ovulating, tracking when our skin might get bad or when our moods might, need to be sort of toned down. And whether or not we should be, going for that HIIT class or maybe just taking that yoga class instead and taking it easy. But for some of our Olympic athletes, understanding how their menstrual cycle influences their peak performance might be the difference between them winning the gold or just becoming famous for their breakdancing skills. So before we sort of get started and sort of start to understand how the menstrual cycle affects our reproductive health, just wanted to shine a light on some of the most amazing athletes, female athletes that were at the Paris Olympics. Both Egypt and Azerbaijan had pregnant athletes win a medal in both fencing and archery. There was an athlete who was 2 months postpartum and won a silver medal. There was a US swimmer who became the most adorned female athlete of all time, which is pretty exciting. She won 5 medals in this Olympics alone. And then there were the British cyclists who broke all the world records. So I think it's pretty amazing, sort of, what women are doing and achieving at the Olympics. And I think what's even more amazing is that we have so many female athletes participating in sport these days.
Indeed. And that brings me on to what I'm going to talk about. So shall I leave you in control of the slides? I think.
Do you want to try and steer the ship, or?
No, I think it'll be okay. Let's see how teamwork can work. So yes, so beautifully introduced, Natalie. Thank you. And it's not just in the context of elite sport where we've seen women's participation increase, and that's an amazing thing, because exercise, in my opinion, and it's shared by lots of people, is the single most important thing that we can do for our health and for our longevity. So we know that exercise can improve your general well-being, your mood, self-esteem, and obviously it can optimize your mental health. In terms of physical illnesses, exercise can reduce the whole magnitude of issues that may happen in future life. It can reduce the risk of cancer, obesity, cardiovascular disease, high blood pressure, type 2 diabetes. The list goes on and on. But we focus, especially here in the UK, we focus a lot upon how we can treat disease. And I'm a massive fan on not just treating disease, but trying to optimize health to ensure that we can live as long and as healthily as possible. And one very important marker of longevity is cardiovascular fitness. So we know that there's a direct correlation between VO2 max, which is your cardiorespiratory fitness, and longevity. And that relationship continues. So the fitter you are, generally, the longer you will live. And of course, the healthier you will live, hopefully.
So it's taking that preventative approach.
Yeah, exactly, which is great. And that's one of the things, obviously, at Hertility, it's allowing women to take control better and to understand and have better autonomy of their overall health, which is fantastic. Coming back to the participation in the Olympics, of course, back in the first Olympic Games in 1896, there were 0 female athletes. Of course, it was an event established by men to compete.
4 men.
So 4 men to show who was the fastest, who was the strongest. And it's great that things have evolved so much, although it's disappointing to see in my lifetime that back in 1984, that just 23% of participants at that Olympics were female. And it's great now to see that almost 50%. So this is back in the Tokyo Olympics. I haven't seen the Paris data yet. I don't think it's been released, but 49% of participants at the Tokyo Olympics were female, which is great. And there's been other changes that have happened over time. In terms of male athletes, the age of those participating has tended to be quite stable since those first Olympics. But with females, we've seen a trend that the age of participants has increased over the last 20 or 30 years. So taking tennis, for instance, back in 1991, the average age was 22, but fast forward 3 decades, and that's increased to 26.
Really unexpected.
Yeah. Well, I suppose so. I suppose anyway. And then looking at soccer, or I can't say soccer with a straight face, football, or women's football. In 1991, the average age was 23, but again, that's increased to almost 27 now in 2023. So that's important. We can fast forward, Natalie. I now know why you wanted me to take control. So other things related to sport, and that's the age of peak performance, or the age of elite athletes varies depending on what discipline or event they're participating in. In things like rhythmic gymnastics, back at the Tokyo Olympics, the average age of participants was just 20. Swimming, it was 22, tennis was 28, and equestrianism, it was 36 years old. And then looking at other events like power events, so those events that require explosive movements, then generally the age of peak performance is lower. It's considered to be in the 20s, early 30s. But looking at endurance events, we see that the age of peak performance continues to increase with the event distance. So it's generally considered to be a much later peak performance, up to the age of 35. And the reason that this is of significance, of course, is that there is a significant conflict between the age of peak performance in athletes and their reproductive potential. We know that as age advances, ovarian reserve declines. So the number of follicles that women have declines, and therefore their number of potential eggs also declines. Now, there's a good ways to assess ovarian reserve, many of which we offer here at Hertility, of course. You could do an ultrasound scan, which we check and we find the ovaries, you can see in the picture on the left-hand side, and we count those little dark holes in the ovaries and their follicles. We count each of those, and that is an antral follicle count. Of course, a scan, it's performed vaginally, it's a bit more invasive, and of course, you need to go somewhere to have it performed. So you could do a blood test instead. So each of these follicles, plus the follicles that you cannot see, produce a hormone, and that hormone is called anti-Müllerian hormone, or AMH. And that's a surrogate marker of ovarian reserve. Again, that's a blood test that you can do on the blood tests here through Hertility. And another more subtle change that can happen is your follicle stimulating hormone, or FSH, can increase as your ovarian reserve declines. And if that's above 10, it can be a marker of reduced ovarian reserve. So the other thing that's a bit more difficult to quantify, which I don't think we offer this yet at Hertility, but maybe if we try hard enough and put enough money into the research department, we might be able to. But
Coming soon.
Yeah. And this relates to egg quality. We know that the egg quality declines as age advances, but at present, there's no way to really know how to monitor it. But we know that the best way so far is to assess the number of embryos that are created from eggs of a specific age and determine how many are chromosomally abnormal. So we call this aneuploidy. So they've got either too many or too few chromosomes, and the vast majority of these will not implant. So women will not become pregnant during this cycle. Those that do become pregnant, most of the time, they will miscarry. Very rarely, there can be a viable pregnancy that does continue, but sadly, it would be affected by a genetic problem like Down syndrome. Now, as you can see, as age advances, you can see that the egg quality, if we just go back.
I'll go back, sorry.
The egg quality in the 20s, less than 20% of embryos will be genetically abnormal. But between the ages of 33 and 37, you can see it begins to increase. So between 21 and 27% will be genetically abnormal. By 37, it's 35%. But then you can see from there on in, the egg quality deteriorates so significantly that the rates of genetic abnormality increase exponentially. So at 40, almost 60% are genetically abnormal. And over the age of 45, 95% of embryos will be genetically abnormal. So that's why the chances of success are much lower as age advances. And this graph represents that. So this graph represents the cumulative pregnancy rates over 1 year of couples having unprotected sexual intercourse. And as you can see, I mean, it's a flat line in the 20s, it comes to the early 30s, but from 34 onwards, it's a line in the opposite, in the wrong direction, really. This is pregnancy rates. So you could look at that and see that the pregnancy rates in 42 to 44-year-olds are 50%, but of course, a significant number of those will sadly miscarry. And the same relationship is seen in terms of IVF outcomes. So the pregnancy and live birth rates in younger women, so under the age of 34, are significantly higher. And as age advances, the success rates continue to decline.
It's basically, you know, we have to try when we're a bit younger.
We do. We need to reproductive plan. And that brings me on to a study that was performed by Habima et al. A few years ago. And unfortunately, it's difficult to do a large-scale research study to assess what age is best to start your family. So this paper, which was published in a good journal in Human Reproduction, did an evidence-based simulation study of 10,000 couples using a proven fertility database. It concluded that couples should start to conceive when the female age is 32 if they want 1 child. This drops to 27 if they want 2 children, and if they want 3 children, they should start at 23. Now, when considering that the average age of first-time motherhood in the UK is now 29, you can see that we're unlikely to be able to have 3 children if we do start that late.
And when we say athletes, how does this compare to those of us who are not athletes? Or are we just talking about women in general?
This is women in general. I'm just contextualizing.
We can all be athletes if we really want to. Is that what you're saying?
Indeed, indeed. So when should athletes plan their families? Well, it's difficult. Off seasons are notoriously short. Tennis, for instance, it's only 4 weeks, and the gestation period in the human, as you know, is 9 months. So it's not long enough to quickly get one out in the off season. Of course, with Olympics, sadly, we've got to wait another 4 years until the next one. But of course, these Olympic athletes will want to be competing in the World Championships, the European Championships, and they won't want to interrupt their training or competitions. So they could either miss a year or 2 of peak performance per child. But of course, this isn't ideal, especially in those disciplines where the age of peak performance is younger, like in short distance or power athletes. Instead, they could defer childbearing until they've retired, or at least after their age of peak performance. But this risks, of course, getting toward the end of your reproductive potential. So it's not ideal for anyone, but of course, especially those endurance athletes where the age of peak performance is that bit later. So these are a group of people who really should be thinking about freezing eggs or embryos to be used after retirement. But of course, that doesn't guarantee a child. And it may well be that when they come back to use the eggs or the embryos, that if it's not successful, they may not have then suitable quality eggs to create further embryos. So what is the impact of exercise upon fertility? And this will be more relatable to the general population. There's very little data in elite athletes. The data that there is generally in small numbers, but I've gone for the best studies and the best quality evidence. And we know that exercise for more than 1 hour a day, at least at a sort of an average of 6 calories per minute, increases the risk of infertility more than 6-fold. This is a study that's more than 30 years ago, and there's been subsequent studies. The next one that I'm going to refer to was done in 2009, and it was a prospective population-based study from almost 4,000 women. And this demonstrated that there was a higher frequency, longer duration, and greater intensity of exercise was associated with subfertility. It showed that in women under the age of 30, women who exercised every day were 3.5 times more likely to be infertile. And those that exercised to exhaustion compared to taking it easy were also 3 times more likely to be infertile.
This argues the case for the rest days.
Indeed. And I'm going to come to that shortly. Because what I need to make very clear, even though it looks like exercise may be bad for fertility, I'll come to it shortly, but exercise, if you're appropriately nourished with appropriate nutrition, I don't believe for a minute is associated with infertility. If anything, it's good for your fertility. And I'll just
like most lifestyle factors, everything in moderation and done with the sort of right care and input means that there's a positive outcome.
Indeed, indeed. So,
and now we're going to touch upon why going to that excess is bad for our fertility.
Yes, I'm going to come to that shortly. I'm going to just do a few more studies just to contextualize further, and then I'm going to try and justify why these things happen. So there was another study, which was an observational study in more than 3,500 women, which also showed an inverse association between vigorous physical activity and fecundability, or ability to conceive. Now, this looked at specifically those that exercise more than 5 hours per week compared to no exercise. And then the last study is a meta-analysis. It was only published a couple of years ago. Now, I'll just explain what a meta-analysis is. It's basically an amalgamation of all the highest quality studies to increase the number of participants to then allow us to draw better conclusion with statistical significance. And this meta-analysis showed that high intensity physical activity was negatively correlated with fertility. So those that exercised to a high level were 16% more likely to be infertile. But it's important to note that there was no such association with moderate intensity, which backs up Natalie's comment about moderation, versus the lowest level. And whilst it wasn't statistically significant, it did show that there was a 9% improvement in fertility in those that exercise to a moderate extent compared to those who are at the lowest level. So looking at IVF outcomes, there was a small-ish study which looked at 273 women on more than 400 cycles. And these are women that engaged upon a median of 2.8 hours of exercise per week. So it's not a huge amount. It's certainly not excessive. It's moderate exercise. And there was no negative impact seen. In fact, those that did aerobics, rowing, or ski machine work had an improvement in their live birth rate. And then there was a systematic review. Again, that's the highest quality data, this time with 8 studies and more than 3,500 women in total. And they compared active women versus inactive women in terms of IVF outcomes. They showed that there was a significant improvement in pregnancy and live birth rates, and they were almost double the chances of success compared to the inactive women. Lastly, women who exercise for more than 4 hours a week. So we're talking about more exercise here. For 1 to 9 years, were 40% less likely to achieve a live birth. And they had 3 times the risk of having their cycle cancelled and double the risk of miscarriage. And looking at all of these data, I think I'm reasonably confident, even though the evidence is conflicting, that exercise is beneficial for fertility. However, exercise that is excessive without appropriate nutrition, I think, is detrimental to fertility. And the reason for that, as Natalie asked about a while ago, is mostly related to an issue which is called relative energy deficiency in sport.
So before we dig into that, so we've talked here, and a lot of the studies talk about amount of time that we exercise, but you also mentioned high intensity versus moderate. And it might be helpful just to clarify what's considered moderate versus high intensity for people who want to relate this to their own exercise regimes.
Yeah, of course. Essentially, moderate exercise would be things like cycling, like running, not, we're talking about HIIT training or sprint training. More intense or vigorous exercise would be exercising to sort of 90%, 100% of your VO2 max or maximal exertion. So in terms of perceived effort ratings, we'll be talking about 8 and above out of 10. Whereas more moderate exercise will be enough to raise your heart rate, things like running a 5 kilometer normal pace, or not a ridiculous pace.
Not a 100-meter sprint.
And then not a 100-meter sprint. So that brings me on to why there are issues related to infertility in women who exercise significantly. And it's called relative energy deficiency sport, or RED-S or REDS, and it's basically driven by low energy availability. Women need at least 45 calories per kilogram of lean body mass to maintain all of their bodily functions. Once this drops below 25, sometimes 20, 30, depending on that individual, they become in a negative energy deficit. If this happens over a long period of time, it can have a multitude of issues related to your health. It can affect your mental well-being, your immune system, all of your hormones, and it can impact the ability to grow your muscles for essentially those gains in the gym. If you're in a negative energy balance, you will not repair your muscles, achieve hypertrophy, improve strength and power. So this is not a good look for anyone that exercises, especially those that exercise at an elite level. Now, the things that I'm more preoccupied with as a gynecologist are the potential impact upon one's reproductive system. And this relates predominantly to the menstrual cycle. So what happens is, over the years, humans and women have been programmed that when you're in this state, so if, for instance, you're in a famine or a war and there's not enough energy, women are programmed to shut down their reproductive system because it's bad for them and it's bad for the baby if they become pregnant. A similar thing happens in women who exercise too much without appropriate nutrition. This can lead on to irregular cycles or absent periods, which of course means that you're not ovulating. If you're not ovulating, that will mean that you're more likely to not get pregnant. If you don't ovulate, you cannot get pregnant.
So the body basically protects itself and prevents it from expending more energy by sort of stopping cycles and leading to an ovulation.
Absolutely, absolutely.
Right.
So the other issues that can be related are, if you're not having periods, then it can reduce, if you're not ovulating. So what happens is when you're, in fact, I'll go through this slide. So what happens on a basic science perspective is your hypothalamus, which is an area of your brain, produces a hormone called gonadotrophin releasing hormone, or GnRH, that acts at another part of the brain called the anterior pituitary to release two hormones, follicle stimulating hormone or luteinizing hormone, so FSH and LH. FSH acts on the granulosa cells of your ovary, and this causes, as the name suggests, follicular development. This in turn releases estrogen, and over the cycle, the estrogen levels increase to an extent where they become very high. This triggers an LH surge, and then you ovulate. In women that have relative energy deficiency in sport, because you're not ovulating, this system is shut down, the estrogen levels are lower, and therefore there's significant implications on your bone health as well. And that comes back to the previous diagram. So you're more likely to get osteoporosis and also suffer stress fractures. So we can go back forward, and essentially, if you don't release the FSH and LH, you won't ovulate. The lower estrogen not only impacts your bones, but it may also impact your endometrium. So this is the lining of the uterus where the embryo will implant. And if that isn't appropriately thick, which happens with the estrogen, then again, it may negatively impact implantation. There's also a relationship with low progesterone levels and luteal phase defects in women who exercise a lot. And it may well be that these women need progesterone supplementation as well. So what do we do with women when they have REDs? Basically, it's reverse the pathology that's been caused. So it's essential to restore the hypothalamic pituitary ovarian axis to reboot those hormones. So women start to have periods again, start to produce estrogen, reverse all of the negative spiral of events that happens, and hopefully start having periods again, and then their fertility will resume. So there's two main ways that we can deal with this. One is we focus on the exercise expenditure or energy expenditure by reducing the training intensity, frequency, or duration. Of course, this needs to be interdisciplinary, dealing with the coaching staff and making sure that they're not overdoing it. Now, at the same time, the other way to tackle this is to improve the energy intake. It's important to have enough protein intake, carbohydrate intake, and get expert dietitian advice to make sure that we're increasing the energy intake and reducing the expenditure to ensure that there is an energy surplus to be able to restore this hormonal axis. Now, there has been historically interrelationship with eating disorders. Of course, this is more likely in those sports previously gymnastics or ballet dancing, where it used to be more sort of aesthetic in appearance, and also those sports where there's weight categories and people need to really get down to specific weight categories. And if there is a significant eating disorder element, it's important, of course, to get appropriate psychological impact. Now, hopefully, once we've done all of these things, we can restore the hormones, restore the periods, and they should start to have regular periods, start ovulating, and hopefully be able to conceive naturally. Now, it's important that all of this is undertaken and we don't just bypass this by using IVF, because we know that reproductive, obstetric, and neonatal outcomes, so this means pregnancy outcomes and outcomes related to the newborn baby, they're much better when the body mass index is normal. So we know that in underweight women, those with a BMI of less than 18.5, there's a 72% a higher risk of miscarriage. And they're more likely to have babies that are of a low birth weight or preterm. They're also more likely to be anemic. So it's important that we focus on all of these things, optimize these women physically before we think about then fertility treatment, which I'll move on to the next slide with.
So just before we go on to that, we've talked about how we can manage RED-S if we get there. Are there any long-term effects of RED-S? So, is there a risk that some athletes are aware of this, and because we can manage it and reverse it, they decide that actually for their career, they're willing to risk it, undertake this strenuous exercise, enter this sort of RED-S, and then decide when the time comes that they'll reverse it? Or, does the body work like that and bounce back? Or are they risking, permanent infertility perhaps?
Good question, because I did refer a few times to the temporary nature of course with regards to the fertility aspect. So whilst the fertility would be restored, it's important to note that there are significant long-term effects that can happen as a consequence to RED-S. This is mostly related to bone health. The bone health that women and men get throughout their early years, you reach a peak. You cannot then add upon it. If you're not at the peak that you would be, then what happens, especially when you get perimenopausal and menopausal, your estrogen levels permanently go down unless you supplement with hormone replacement therapy. And you are much more likely to get osteoporosis. That is very hard to come back from. Osteoporosis increases your risk significantly of stress fractures in terms of training. They're more likely to get injuries. And of course, in the future, serious fractures, hip fractures, arm fractures, things like that. Now, it's important that you allude to a type of mentality that sportswomen have, and it was certainly much more common years ago. We're now seeing a change because we know that this doesn't just affect periods, it doesn't just affect bone health. And you're right, athletes would probably sometimes be willing to potentially risk their health for success because they'll do anything to succeed.
Exactly. And, especially if we talk about how it can be managed, I don't know how often we're thinking about the long-term effects of some of the decisions we make in the moment. Yes,
indeed. But they should be reassured that if they restore, if they treat their RED-S, then their performance will get better, their strength will get better, their power will get better. They're not going to be as healthy or as good performance-wise in this state. So we try to persuade these women into a different mindset. Of course, it's not always difficult, it's not always easy. In fact, it's always very difficult, and reducing training intensity is probably the hardest one. But essentially, if they get appropriate nutritional input, hopefully they'll be able to restore things quickly so they can get back to their normal training regime. So from a fertility perspective, what else can we do? Now, once they've been optimized, then there's two options really. I mean, one, their period should resume, they should start to ovulate, and it may well be that they just need a bit of progesterone support after they ovulate. Otherwise, we can help them ovulate or encourage them to ovulate or potentially ovulate more than one egg per cycle. And we can use certain medications like clomiphene and letrozole to do this. But there's additional complications in elite athletes. For instance, the World Anti-Doping Agency prohibits the two most commonly used agents for ovulation induction, so clomiphene and letrozole, because they're performance enhancing. So if you do use these medications, they need an exemption certificate. Not only would this be stressful, it may impact their ability to perform and compete during certain competitions. Instead, you could use exogenous gonadotrophin. So this is what we use for IVF, like FSH and LH. And these are WADA compliant, but it does increase the risk of twins, and it does increase the risk of ovarian hyperstimulation syndrome. Alternatively, women could use IVF, and they could use those eggs or embryos that they may well have already stored or undergo fresh cycles. But one of the important things and the benefits of IVF is that you can plan for more than one baby if you create enough embryos. And of course, if you create embryos at a younger age, the success rates of those embryos will remain the age at which they were created. So with IVF, you would have the opportunity to embryo batch and get enough babies to hopefully meet your reproductive aspirations. However, there are still risks related to WADA prohibited medications, and there's various commonly used medications that we use that are WADA prohibited. So it's important to make sure that these athletes are treated by appropriate trained fertility specialists. Testosterone, I suppose that one's an obvious one. It's performance enhancing, and there's DHEA as well. We sometimes use these to improve ovarian reserve, particularly in those low ovarian reserve patients, to improve egg yield during stimulation. We also use growth hormone in similar cases, and I mentioned letrozole and clomiphene. We use that for ovulation induction, and we also sometimes use these to improve outcomes along with FSH in women with low ovarian reserve. We also sometimes use steroids like prednisolone if women have immune causes of infertility. And that's another one that's WADA prohibited. So all of these things require consideration in women undergoing IVF if they're competing at an elite level.
A lot to take into consideration here, and IVF itself, even if you're not an elite athlete, can be quite stressful. And then on top of it, trying to manage, medications that allow you to perform and compete, adds that extra layer of complexity.
Yeah, indeed.
And are there, clinicians like yourself working with athletes, around these to sort of help them plan and ensure that they're aware of it? Because we know, in the general population, a lot of our users, we sort of educate them around their bodies, and they're not elite athletes. It's a missing piece of the puzzle in our education system. And I can imagine that for athletes, it might be even worse.
Yeah, absolutely. And so for me, that's probably the most important message for elite athletes. It's just being aware of reproductive aspirations, engaging with reproductive medicine or fertility specialists to help plan your family. You don't have to put your head in the sand and continue to train, not think about having a family, and then hit 40, retire, and then start thinking about your family. I see that every single day, not necessarily in elite athletes, but in women. And that alludes to, like you said, and the reason I wanted to talk a bit more about the family planning, even if there's not elite athletes that are joining this webinar, it relates to everybody. And like you say, everyone needs to be aware of their reproductive potential. They need to make appropriate reproductive aspirations that are fully informed based on information about egg quality and based upon their own ovarian reserve. And it's important to individualize for each woman, no matter if they're an elite woman or someone that's just exercising, to be healthy. So I'm going to talk more now about a paper that we published a few months ago now, which looked at the menstrual cycles and the impact of menstrual cycles upon the performance in elite, mostly Olympic British athletes. So we sent a survey to these athletes over a 5-year period every 6 months. 128 participants consented and took part, and we showed a number of interesting things. We showed that the mean age of women starting to have periods, so we call that menarche, it was later in endurance athletes. So we saw that in endurance athletes, that mean was over the age of 14, whereas in throwers, it was towards the end of being 12 years old. Now that shows that this problem isn't just a problem that women get as they get a bit older when they're competing for Olympic titles or national titles. It's a problem that kids are having, because of course how this presents in younger children who are not having periods is delayed periods, and endurance athletes are much higher risk than the power or the throwing athletes. So moving towards the results that we saw in the older, it's all in older athletes, but of course it was referring to when they started to have periods. But now looking at their periods now, 2/3 of them, so 66%, reported that their cycles were regular. However, when looking at those, when specifically asked, 43% of them had a more than 5-day variation in their cycle over the last 6 months. So not only were these women thinking they were having regular periods when actually they weren't, but they were almost normalizing it, which again refers to some of those things that we were talking about earlier, Natalie. And 30% of them straightforward said their cycles were irregular, and 4% weren't having periods at all. So overall, 60%, that's almost 2/3 of these athletes, had some form of menstrual disturbance. And actually, more than 2/3 of them described that their periods were significantly painful. And almost 1/3 of them said that their periods were particularly heavy. All of these things are going to potentially negatively impact performance.
But what's really interesting is, like the general population, they just assumed it was normal.
Yeah, absolutely. And then when asking specifically what if they thought that their periods or cycles had a negative impact upon their performance, more than 3/4 of these athletes felt that it did. And the most common time for these women that they thought that their performance was most negatively impacted was in the late luteal phase, so the days leading up to their period. A similar proportion, so 35%, actually felt that it was during their period in the early follicular phase. Almost 80% of women also reported at least one significant PMS symptom, with bloating, lower back pain, and pelvic pain being the most frequent. Now, I'll talk you through a bit more about the cycle, a bit more about the hormones, and a bit about when women or athletes may have the best level of performance in their cycle. You can see on the graph here that you can split the cycle into crudely 2 different areas: the first 2 weeks and the second 2 weeks. The first 2 weeks is called the follicular or proliferative phase, and this is largely under the influence of estrogen. This is when those follicles are developing, they're producing estrogen, and estrogen can increase vasodilation. It can promote glucose uptake into muscles, which can improve the ability for muscular contraction. And estrogen can enhance the preferential metabolism of free fatty acids over using stored muscle glycogen, which may also have an endurance benefit. Now, the second 2 weeks of the cycle is called the luteal phase. And whilst the estrogen level is still high in this phase, the progesterone level also significantly rises. And progesterone has a more thermogenic effect, so it can increase your core temperature, which may negatively impact sleep, which sleep is really important in recovery, but it also negatively impacts metabolic rate and can negatively impact cardiovascular strain. So looking at the data in the study that we did, the times where athletes are reporting a negative impact upon their performance are times when their estrogen levels are low. So at the start, so when people are having their period, or at the end, when the estrogen levels have declined. And there was a recent meta-analysis performed which looked at the effect of the menstrual cycle phase on endurance and strength, and did find a small but significant reduction in performance in that early follicular phase when the estradiol levels were low. So whilst the evidence is conflicting, it is only a small impact in that meta-analysis. And the data that I've got, whilst it's in elite athletes, it's not a huge number, so it's difficult to draw confirmed conclusions from it. But logically, and from what the data suggest, between day 7 and day 21, so to your mid-luteal phase, would be the best times in terms of athletic performance based on that information.
So I can continue to use my late luteal phase as an excuse to get out of HIIT classes and all those things.
Absolutely. So to summarize, obviously elite sportswomen clearly face a dilemma between reproductive and competition planning. because of that conflict between peak performance and reproductive potential. They are therefore at risk of age-related reproductive decline, and they really should consider egg or embryo freezing, or at least have conversations about it throughout their career to make sure that they're fully informed and that they're making the right decisions for them. Menstrual irregularity is clearly very common in elite level sportswomen, and we know that these menstrual symptoms can negatively impact their performance. It appears that vigorous exercise is associated with reduced fertility, but as I mentioned earlier, it's very clear that I don't believe, and the data is not there, but in women exercising vigorously who are appropriately well nourished, having appropriately nutrition, good protein, good carbohydrate intake, that are having regular cycles, I do not believe for a minute that they will have any issues conceiving. I suspect their fertility is much better than their inactive counterparts. We've also seen that in IVF outcomes are better in active women compared to inactive women. Again, they are likely to be suboptimal in women with Red S. The key, of course, is to fuel their bodies and your bodies to ensure that you've got appropriate nutritional intake to optimize your performance, overall health, and also fertility.
Wow.
Thank you. Any questions? Maybe
So we actually have a whole list of questions,
do we?
The audience. So I'm gonna pick 3 before we sort of wrap up. But I think one that's quite topical, because there's a lot of controversy around it in general, is someone once has asked, does hormonal contraception play a part in elite athletes or vigorous exercise performance? And if so, what kind of contraception would you advise elite athletes to take?
So, excellent question. I probably should have put a slide or 2 in there, actually. I always individualize it. In terms of contraceptive options, I don't really consider the sort of systemic progesterone options. So we're talking about the Implanon, so the implant or the injection or the progesterone-only pill. The reason for this is that these have high doses of progesterone. They go around your body. They cause progesterogenic side effects, things like bloating, mood swings, breast tenderness, which are not good. They're not great for anyone, let alone women who are trying to compete. I also don't consider the copper IUD, really. Sometimes if women don't want hormonal contraception, then it is a good option, but in most women it causes heavy, sometimes painful periods. And again, that's not a good look for anyone, let alone elite athletes. That leads us on to 2 main options. One's the combined oral contraceptive pill, and the other is the Mirena intrauterine system. With the combined oral contraceptive pill, we know that there's a systematic review that's shown that overall, there's been a small but reduction in peak performance in women taking the pill. We know that that's likely as a consequence to having a lower VO2 max and a lower anaerobic capacity in women when they're taking the combined oral contraceptive pill. There's also more subtle changes that can happen. There's a part of your brain called the amygdala. And this is basically a part of the brain that's associated with fear. And we know that the hormones and the regulation of the response to the amygdala is altered when you're taking the combined pill. This may impact your decision making and your willingness to take chances during sports. So I don't generally recommend the combined pill because it's generally associated with a worse performance. I'd much rather my patients be having natural cycles if possible. Now, of course, they may have particularly heavy, particularly painful periods. In the first instance, I would always try and investigate that, try and find out if there was a cause and treat the underlying cause, whether or not it was hormonal or structural in nature. If the benefit of then having hormonal contraception outweighs that potential, the potential risks, then of course that's a discussion that we have. If I do choose an option, or if women really want hormonal contraception for contraception as opposed to treatment or optimization, then I always recommend the Mirena intrauterine system. This tends to give very light periods. Sometimes, in fact, most of the time after 12 months, women will stop having periods, and it does not have that same systematic effect that the combined oral contraceptive pill and the other hormonal contraceptive options have. So whilst I wouldn't blanket recommend that women get the Mirena, I think it's the best option in most of the cases. And I always try and avoid the pill if possible, and the other options.
I think there's a lot of research also that needs to sort of be done around contraception and the pill for both athletes and all of us as well. This isn't pertaining necessarily to athletes, but our next question sort of touches upon your point about nutritional needs being met. And sort of in the last few years, intermittent fasting and fasting in general has become quite common, and you know, there's a lot of hype around it. Sort of what's your opinion on fasting and how it might affect, you know, hormonal and menstrual cycles, especially, you know, both, you know, in regular everyday to day life, but also if you're training, especially training, you know, quite vigorously?
Okay, great question. Fasting, I think, is great for men, and it's good for certain women. Mainly,
what kind?
So mainly women who are overweight, especially those that have comorbidities, things like diabetes or polycystic ovarian syndrome. We know that, especially with polycystic ovarian syndrome, women can have irregular periods. If they lose 5% of their body weight, often they can restore ovulation and improve their reproductive outcomes. So in those type of women, I consider it as an option. But for most women, I do not recommend it. I know it's very popular. It can allow women to lose weight, but it can also have a myriad of issues, and it's all related to what I've been speaking about. What happens, say in the morning, what happens, people wake up, they half an hour after you wake up, you get a cortisol spike. So your circadian rhythm starts. The cortisol is basically a stress hormone, and it gets your body going. Now, what do most people do? Most people have a coffee. Caffeine, it's a stimulant. It will only make that stress response even worse. So if you're not eating anything, if you had some complex carbohydrates or some protein, it would really reduce that cortisol spike. So then, if you then go out and exercise, cortisol spike, coffee, exercise, that's putting your body into this big stress. What happens is your body goes into a fight or flight response, and it goes into a catabolic state. So it starts to break things down. The first thing that gets broken down is lean muscle mass. It's not fat. It's the opposite of what most people want. What I tend to advise is that when people wake up, especially if they're going to exercise early in the morning, it's important to try and have a bit of protein before you exercise. I try and get 10 grams, 15 grams of protein before you exercise. Now, some people wake up and they don't want to, they're not hungry. And that's really difficult then to try and get something down. But sometimes like a protein shake or putting a scoop of protein with your coffee can actually help fuel your body. Now, if in women who appropriately fuel their body at this moment of stress, you get a growth hormone response, testosterone release, which you don't get if you're in that catabolic state. What that does is it improves adaptation, it improves muscular regeneration and hypertrophy, and it decreases the cortisol and your stress response, and it will make you feel 1,000,000 times better. We know that, and then ultimately, whilst I think it's just better for your general health and for your athletic or performance, we know that fasting is bad from a hormonal perspective. And all of this will increase the risk of getting irregular periods. We know that in published data in women during Ramadan, for instance, that more than double during Ramadan, women have got double the risk of having menstrual abnormalities compared to before or afterwards. So fasting is a good option in some women if it's appropriately monitored, done sensibly, but in most of the time, I do not recommend fasting in any of my patients.
I think, the overall theme that we've sort of picked out and sort of come across here is that, it's all very personalized, and that, medicine, whether you're an athlete or not an athlete, it's all tailored and individual to you and what your body type is and what your body type needs.
Absolutely.
So
Absolutely.
I think we have time for one more question. Los Angeles 2028, what sport are you competing in?
Was that me?
Yeah,
No,
you're going to
So
you get to pick. You were going to be an Olympian.
I should have been a professional footballer, but sadly that wasn't to be. So now I'm just a budding cyclist who cycles to work.
So we'll see you around the velodrome then.
Indeed, maybe. Who knows?
Well, thank you, Dr. Ben. It's been, there's a lot of information here. And I think, even if those of us who aren't elite athletes, who aren't sort of, doing vigorous exercise, can take some of this on into our day-to-day lives and sort of implement some of these things when we are exercising in order to maintain a healthy lifestyle. Thanks, guys. Thanks for tuning in.
Thank you.